Everybody hear me? Mic's on? Good deal. Well, there it goes again. I want to thank everyone for coming today. I'm Dr. John Bienvenu, for those of you who don't know me, I'm an assistant professor of medicine in the section of gastroenterology and hepatology. And today I'm going to be talking about the gastrointestinal complications of diabetes, which encompass quite a few other problems besides gastroparesis, which is the thing that all of us are the most familiar with in diabetic patients. When I was trying to think of a topic for today's grand rounds, at first I thought, well, I'll do some really obscure GI topic and maybe nobody will come, or I can choose a topic that should be applicable to everyone in the room, no matter what field or specialty that you go into in medicine. I'd like to start out by saying I have no conflicts of interest or commercial interest. And the objectives today, I would like practitioners to be able to list the most commonly encountered GI symptoms and their affected organs. I'd like for healthcare professionals to take from this lecture the knowledge where they can decrease GI manifestations of diabetes by identifying and treating the diabetic-related GI diseases early, and then use available therapies appropriately to treat the symptoms related to hyperglycemia and diabetic neuropathy. Key points, the few key points I'd like to mention before we get going. When practitioners think about the complications of diabetes, they often focus on the microvascular, macrovascular, and peripheral neuropathic complications that are known to be associated with the disease. And although GI symptoms are extremely common in the general population as a whole, they are even more so in diabetic patients. So 40% of the general population will have some adverse upper GI symptoms, but if you look at diabetic patients, over 75% are going to experience some kind of upper adverse GI symptoms. And these symptoms not only have a detrimental effect on quality of life, but they also have significant medical consequences. And the poor control of diabetes can really affect any segment of the gut from the mouth to the rectum. And some of the things that, see, going ahead of me. Some of the topics we will discuss briefly today include gastroparesis. We'll go into some depth there, but also small intestinal bacterial overgrowth, diabetic diarrhea, and fecal incontinence, amongst others. As mentioned on the previous slide, diabetes can attack any organ in the body, and that includes any organ in the GI tract. So you can have a reduction in esophageal motility, leading to symptoms of dysphagia. Chronic diabetes can reduce the resting basal tone of the lower esophageal sphincter and result in increased reflux symptoms. You can have poor fundic contraction causing early satiety, and then also poor motility in the stomach resulting in the gastroparesis that we're all familiar with, and its associated nausea and vomiting. You can have increased or decreased transit time in the small intestine or large intestine, as well as an alteration in the microbiota of the small intestine, resulting in small intestinal bacterial overgrowth and diarrhea. It's a busy slide, but I think it does a good job summarizing some of the main mechanisms at play that are involved in the enteric nervous system that result in impaired GI motility. The mechanisms here, some of which aren't very well known, they're fairly complex and multifactorial. But if you look at autonomic neuropathy, this can affect both the afferent as well as the efferent connections between the enteric nervous system and the CNS. Diabetics also tend to have a reduction in the number of enteric neurons in the GI tract. This is due to reduced number of cells. The decrease in motility is often due to a reduced number of enteric neurons, and this is caused by increased apoptosis or cell death due to oxidative stresses. And some of the cells that are key players in the GI tract are the interstitial cells of Cajal, and they can have their numbers can also be reduced by reduced growth factors in the GI tract, as well as oxidative stress and apoptosis. Smooth muscle can have an abnormal motility which causes decreased contractility, and there's impairment of the intracellular signal and impaired phosphorylation of the myosin light chain. Additionally, there's a lot of interaction between the gut and the CNS, and when that gets damaged, then you can have changes in the motility, changes in the GI secretions, as well as an increase in the permeability of the gut, which can have adverse symptoms. The slide's a little busy, but it summarizes some of the affected organs, their common symptoms, and pathogenesis. So again, we're looking at the esophagus, stomach, small intestine, large intestine, and even gallbladder. And if you look at the abnormalities listed, all of them have to do with dysmotility as being a primary cause. Even in the gallbladder, where gallstones, cholelithiasis, and choledocholithiasis is listed, the main factor thought to be at play here is relative stasis of bile in the gallbladder. Talk about that a little bit later as well. But one thing to keep in mind is that the pathogenesis as well as the symptoms of these problems are all enhanced in the presence of acute or chronic hyperglycemia. And overall, type 1 diabetics are thought to have a higher risk of neuropathy due to their typically having a longer duration of disease and therefore hyperglycemia as a whole. So going back to the interstitial cells of Cajal, these are very important cells. They're essentially the electrical pacemakers of the GI tract. And they control the myoelectric activity and influence gastric emptying. There are several types of these interstitial cells of Cajal in the stomach. The first is those found in the myenteric plexus, which control the slow electrical wave activity, just kind of the slow rhythmic pulse within the stomach to help propel food towards the antrum and through the pylorus. But there are also other interstitial cells of Cajal located in the inner circular muscle, as well as those located in the outer longitudinal muscle. These two types of interstitial cells of Cajal are associated with cholinergic excitatory activity. This really is a beautiful image that shows the interstitial cells of Cajal in tissue taken from the left colon of both a normal patient as well as a patient with long-standing diabetes and known autonomic neuropathy. The interstitial cells of Cajal are lit up in white, and you can see on the left-hand side, and again, this is a normal patient, but there are these nice, really pretty filamentous projections that kind of intercalate amongst the smooth cells of the intestines, and as well as you can see all these kind of background starry sky type picture in the background here that you don't see at all over here in the patient with a diabetic neuropathy. Their numbers of interstitial cells of Cajal are reduced, and they lack those nice filamentous processes that are seen in the normal patient on the image on the left. And this suggests that there has been some damage to these cells, and that they likely play a role in the development of adverse symptoms related to the slowing of motility. What keeps the balance in terms of regulation of the number of interstitial cells of Cajal? It is thought that the number of these cells stays relatively constant in the body. There is some decrease as we age, but overall, it's a fairly steady state. You know, you have a nice balance between cell death and the transdifferentiation of stem cells into other cells besides the cells of interstitial cells of Cajal that is balanced by increased proliferation of these cells or increased survival. And when this gets out of balance and you lose numbers of interstitial cells of Cajal, then this often results in adverse GI motility and GI dysmotility, and you have this subsequent development of an abnormal interstitial cell of Cajal network. This is kind of a neat study that looked at patients who were undergoing gastric electrical stimulator placement for refractory gastroparesis. And this gave the researchers an opportunity to take full-thickness antral biopsies from these patients while they were in the operating room and look at the the nerve cells and the number of interstitial cells of Cajal in diabetic patients compared to normal patients that had gastrectomies for reasons besides diabetic gastroparesis. And I've highlighted the controls in yellow as well as those who had diabetic gastroparesis. And if you look at the number of ganglia per high-powered field, as well as the total neural cell bodies per high-powered field of those with diabetic gastroparesis compared to the controls, they had a statistically significant reduction in the number of these cell bodies or ganglia compared to the non-diabetic patients. Additionally, when they looked at the different histologic layers of the stomach, the interstitial cells of Cajal that were in the myenteric plexus of the diabetic gastroparetic patients were also statistically significantly reduced compared to those of the control. Again, this strongly suggests that they at least play some role in the development of impaired motility of the stomach. This is a H&E stain of a myenteric plexus in a normal patient and the ganglia, and it's nice and healthy appearing, but on the right, this is a patient with diabetic gastroparesis, and there's a lot of lymphocytic infiltration in the intermyenteric plexus, and it's thought that this chronic inflammatory response also plays some role in the adverse motility. So these are some of the major topics we're going to continue to talk about. I'm going to spend a lot of time on the gastric disorders as well as the small intestinal and large intestinal disorders, and just due to time restraints, just briefly touch upon hepatobiliary disorders and pancreatic diseases. Let's start with esophageal disorders. So as we talked about earlier, there are a lot of different abnormalities that can develop in the esophagus of patients with poor glycemic control and diabetics, including the diminished amplitude of contraction, the reduced coordination of contractions, or the prolonged esophageal transit. The three of these can result in dysphagia symptoms. And a lot of this is also thought to be due to vagal nerve dysfunction as well as motor nerve dysfunction. Symptoms are the ones we're fairly familiar with, which can include heartburn, chest pain, odynophagia, and dysphagia. And in terms of evaluation, we tend to rely on these three modalities for evaluating their symptoms. Upper endoscopy is often performed, especially if they are having symptoms of dysphagia or odynophagia. But if there's some question as to the role of acid reflux or even non-acid reflux in these patients, then we'll often use 24-hour or 48-hour pH monitoring. And if there's any suggestion of impaired motility in the esophagus after upper endoscopy is performed to exclude obstructing lesions or other mechanical causes for their symptoms, then we'll often employ high-resolution manometry. In terms of treating motility disorders of the esophagus, the treatment options are fairly limited. Lifestyle modification becomes a big part of this, and as well as reassuring the patient that while they do have some symptoms, there are some changes in their dietary habits that they can employ to help reduce the symptoms and hopefully not have them progress. In patients that may have some spasticity, calcium channel blockers or nitrates have been employed with differing success rates. So these are two images that show esophageal manometry, and first need to understand that when we do this procedure, a catheter is passed into the nostril and then down the esophagus, and the distal tip resides in the stomach. And along the length of the manometry catheter are different pressure sensors. And these pressure sensors are constantly recording the pressure that they see within the esophagus. And so this is a conventional manometry tracing showing a swallowing or showing a single swallow by a patient. Here's the upper esophageal sphincter. When the swallow is initiated, there's a very brief increase in the pressure gradient, and that is followed nicely in a diagonal fashion over time, because time is the x-axis here, until there's a decrease. This is the lower esophageal sphincter here, and there's a nice relaxation as the lower esophageal sphincter opens and the food bolus is propelled down into the stomach. The major difference between conventional manometry and high-resolution manometry, as depicted on the right, is that in high-resolution manometry, the sensors are typically spaced about every 1 centimeter apart along the length of the catheter. And so you have, as opposed to only 5 or 6 different measurements in the conventional manometry, you have about 36 different pressure sensors recording the intraesophageal pressure at one time. And this allows the computer to then generate an esophageal pressure topography in a somewhat three-dimensional form that depicts the pressure gradients within the esophagus. And this gets depicted in different colors on the manometry readout, so that areas of low pressure are in blue, and that high pressures are in red. One product available for the measurement of 24-hour, 48-hour pH studies is something called a Bravo catheter. This is inserted endoscopically into the patient, and the catheter is actually left just a couple of centimeters above the lower esophageal sphincter, and it's kind of adhered by suction to the wall of the esophagus and stays in place while the person goes about their daily activities and records the pH of that portion of the esophagus over time. And the patient also records in a log when they experience reflux symptoms, and you can correlate the readings from the pH probe to the symptoms recorded by the patient to see if there's any correlation between acidic events and symptoms. Oftentimes, they don't correlate, but this is one modality that we can use. The other one is the other modality for measuring pH over time is to insert a very slim catheter into the nostril that is also positioned just above the lower esophageal sphincter, and that stays in place for about 24 hours. It's not quite as comfortable for the patient as the probe in the esophagus. GERD is very commonly encountered in these patients. In fact, general population may have about a 14% prevalence of reflux symptoms, though those with diabetes actually have 41%. And practitioners should be mindful of the association and be aware of the incidence of GERD when a diagnosis of neuropathy is made in a diabetic patient. So there are risk factors for the development of GERD in diabetic patients. These include cardiovascular, autonomic dysfunction, elevated BMI, those who have a longer duration of their disease or who have particularly poor glycemic control. And the management of these symptoms really, even if you prescribe a medication for them at that initial visit, we really should be talking to them about lifestyle modifications, which include the avoidance of trigger foods such as tomatoes, citrus, spicy foods, heavy, greasy, fatty foods, etc. Weight loss plays a big role in improvement of reflux symptoms. Even modest amounts of weight loss, 10 to 15 pounds, can result in dramatic improvements of reflux symptoms. When needed, we tend to use H2 blockers or more commonly PPIs for therapeutic treatment, and we're all familiar with these. However, when the symptoms of GERD don't respond to a PPI, the underlying diagnosis should be questioned. And in patients with a long-standing history of GERD, especially those who are middle-aged Caucasian men who happen to be obese, then it's important that they get screened for Barrett's esophagus, because that has very important implications for them long-term. One of the problems we see in diabetics that are particularly poorly controlled includes esophageal candidiasis, which can be completely silent, or it can present with fairly significant odynophagia because of the inflammation caused by this fungal infection in the esophagus. You know, the esophagus is a very nice, warm, moist environment, and if you have hyperglycemia, they have all the fungi have all the energy and nutrients they need to thrive, and it's not uncommon for us to see an endoscopic picture looking down the esophagus that appears like this. It's fairly prominent and fairly obvious. When we see this, we don't even take biopsies typically. We just treat it. You should get in the habit of looking in your diabetic patients' mouths to see if they have any evidence of oropharyngeal thrush. If they don't have any esophageal symptoms, it's reasonable to treat them with just swish and swallow a nice statin. But if they have odynophagia, typically we tend to proceed directly to oral or IV fluconazole for a 2 to 3 week course of therapy to treat them. Moving on to gastric disorders, and I'm not sure what's happening here. Excuse me. Not sure why it's advancing on its own. As we talked about earlier, the consequences of diabetes can lead to the disruption of different components of the process that result in gastric motility. You can have a reduced fundic tone, reduced in the frequency as well as force of antral contractions, as well as poor relaxation of the pylorus to facilitate gastric emptying. We talked about earlier the interstitial cells of Cajal tend to be the major pacemakers for the stomach and its motility. And when you lose these, then you tend to develop symptoms of gastroparesis. Additionally, there are typically vagal nerve abnormalities that can result in the reduction of postprandial gastric acid secretion. And the hyperglycemia can also disrupt the coordination of the contractions and emptying even in healthy controls. This was a pretty neat study that was done in the late 90s that looked at gastric emptying rates with both solids and liquids in healthy and diabetic patients that had diabetic gastroparesis. So on the left is the healthy, normal patient, and on the right is a diabetic patient, and the open circles on each graph are represent the solid component of a meal, whereas the closed circuits are liquid components. The same holds true for the open triangles and the closed triangles. So they established a fairly steady state blood glucose concentration in each group, the normal patients as well as the diabetic patients, at 2 different values, 4 millimoles per liter of blood glucose and 8 millimoles per liter of blood glucose. And they measured the emptying of the stomach and the percent of retention over time. And you can see that even in normal patients that don't have diabetic gastroparesis, a hyperglycemic state in the acute setting resulted in decreased gastric emptying compared to the lower blood glucose level of 4 millimoles per liter. Diabetic patients with the diabetic gastroparesis, they emptied even slower compared to the normal patient on the right. Typically, solid meals move more slowly out of the stomach than liquid meals, and this was represented on each of these exams, with the open circles being the solid meals and the open triangles as well being the solid meals. Any questions on that? In terms of diagnosing gastroparesis, the symptoms of nausea and vomiting, early satiety, lack sensitivity and specificity. But these symptoms tend to be the best predictors of gastroparesis in diabetic patients. If we perform an upper endoscopy on a patient and they have been fasting for 12 hours, yet we find food in their stomach on upper endoscopy, then that is a good suggestion that they have some degree of delayed gastric emptying and should raise the suspicion for gastroparesis. Consensus guidelines recommend that diagnostic testing be performed to confirm the diagnosis of gastroparesis, and we typically use scintigraphy to measure this. For this examination, patients eat a meal that has a defined caloric content and has been labeled with technetium-99, and then they measure the radioisotope activity in the stomach over time. And there is a tendency in many hospitals for these studies to be performed only out to 2 hours. But in order for you to get the best study, you really need to go all the way to 4 hours. This is a nice example of why this is important. So on the left, this is what the nuclear medicine counter, the scintigraphy counter, is measuring. So this is the stomach at 0 minutes, it lights up very well. There's a high concentration of the radioisotope in the stomach, and then over time you see that activity level in the stomach slowly decrease. This is a plot that represents that radioisotope activity in the stomach over time, and that is what the radiologists use to determine if there's an impairment of the gastric motility and emptying. So this patient has an abnormal 4-hour gastric emptying study because at the completion of the exam at 4 hours, he or she had about 35% retained radioisotope in their stomach, whereas the normal at 4 hours should be no more than 20%. Okay? Normal at 2 hours is about is no greater than 40%. I'm sorry, no greater than 25%. So they actually meet that that cutoff here. But if you stopped the study at 2 hours, it appeared that this was a normal exam. But by taking it all the way to 4 hours, they showed that they still had about 30% retained in their stomach, and thus they have an impairment in their gastric emptying, and gastroparesis is confirmed. So there should be 3 goals for practitioners in treating patients with gastroparesis. Number 1, you need to evaluate and correct for the nutritional status of the patient. You need to do what you can to improve the degree of gastric emptying as well as treat their symptoms. In terms of initiating this, you need to look at their nutritional status. So gastroparesis may interfere with oral intake and nutritional status, and therefore the first goals of management really are to restore hydration, replete electrolytes, and ensure that they have sufficient long-term oral intake. Alcohol and cigarette smoking should be avoided, as both of these have been shown to reduce gastric emptying. Dietary modifications for gastroparesis tend to optimize the emptying of the stomach while avoiding foods that may delay motility, such as those with high fat and fiber content. A gastroparetic diet is one that consists of small, frequent, low-fat, and low-residue meals. And if individuals are unable to tolerate modified diets, then liquid meals may be trialed, as the gastric emptying of liquids is frequently maintained in gastroparesis or better tolerated than solid food components. In severe cases, where patients lose greater than 10% of body weight over a 3 to 6 month period, sometimes it is considered that these patients undergo feeding tube placement so they can achieve enough caloric intake to meet their nutritional needs. Based on the experimental models that we looked at a few slides ago, hyperglycemia delays gastric emptying in patients with diabetes as well as in healthy patients. And management of the gastroparesis really should include optimization of glycemic control and improve short-term symptoms. So for patients on mealtime insulin, their timing of the mealtime bolus may have to be adjusted. Rapid-acting insulin can be dosed at the start of the meal or about 15 minutes after starting a meal in an attempt to match their peak insulin levels with the appearance and rise of glucose within their blood. And similarly, you sometimes have to switch from rapid-acting insulin analogs to regular insulin in an effort to do the same thing, to match their insulin levels to blood glucose levels. There are current medical treatments for diabetes, which include pramlintide and GLP-1 analogs, such as Victoza, Byetta, these are the trade names of them, that actually can result in delayed gastric emptying and exacerbate symptoms of gastroparesis. And if you have a patient that is requiring prokinetic agents to treat their gastroparesis symptoms, you really need to avoid these medications altogether. In terms of the pharmacotherapies that are available for their treatment, there's only one that is FDA approved for the treatment of gastroparesis, and this is metoclopramide or Reglan. I think we've all seen it or are familiar with it. It is a D2 dopamine receptor antagonist and has a less potent stimulation of the 5-HT4 receptor as well. It has several properties in that it increases the lower esophageal sphincter tone and can reduce some reflux symptoms. It can increase gastric pressures and the degree of antral contractions within the stomach. And also, it can provide some antiemetic action by inhibiting the D2 dopamine and 5-HT3 receptors in the chemoreceptor trigger zone. And although this is the only agent used for or approved by the FDA for the treatment of gastroparesis, most of us don't know that its use is only approved for 3 months' time. You need to give them a drug holiday at that point. So be careful if you have patients that are on chronic Reglan, because if you don't discuss the risks and benefits of the drug with them, you might find yourself in some trouble if they develop some of the adverse symptoms that are associated with its use. Reglan actually has a black box warning because of the very real risk of the development of tardive dyskinesia. And this is a disorder characterized by involuntary movements of the face or extremities. And it's induced by the dopamine inhibition that metoclopramide causes. The incidence is very low, fortunately. It's less than 1%, calculated to be about 0.2%. But because of its potentially irreversible nature, it really needs to be discussed anytime you start a patient on metoclopramide. And explain to them that should they have the development of any of the CNS effects that it can cause, including the tardive dyskinesia, they need to stop its use immediately. Groups at highest risk for the development of tardive dyskinesia include patients that are on higher doses of the drug, those of younger age, and women in particular. You can also have some prolongation of the QT on EKG, as well as some Parkinsonian movements, akathisia, and hyperprolactinemia. Guidelines for the use of the drug recommend that you use the minimal effective dose, you constantly monitor the need for its continued use, and you give drug holidays where possible. So this study was done to kind of prove that metoclopramide both improved gastric emptying as well as symptoms of gastric stasis. The improvement of gastric emptying should decrease the symptoms in these patients. However, symptoms were markedly reduced in patients whose gastric emptying was improved, but the emptying was still very slow. So here they had a scoring system for global symptoms or for vomiting in patients with diabetic gastroparesis who were first given a placebo and then asked to score their symptom, global symptom or vomiting symptom severity. 3 being the worst symptoms, and 1 being and 0 being the least severe. Patients that were given a placebo, this is where they started, and then when they were given metoclopramide, they were asked to reassess their symptoms, and you can see across the board they improved in both global symptom severity as well as vomiting. Additionally, they measured the amount of gastric emptying, degree of gastric emptying with use of metoclopramide. So this is a pre-treatment arm, and then after they were given metoclopramide, you can see that generally speaking, the degree of gastric emptying improved with its use compared to placebo, where they really did not expect to see any improvement, and across the board really did not. So relief of these adverse symptoms in these patients is really twofold. Metoclopramide can increase gastric emptying and also inhibit the vomiting center in the CNS. A couple other therapies that are sometimes discussed or used include domperidone. Who here has used domperidone? No one. Not a single person. It has a similar mechanism of action to metoclopramide. However, it doesn't typically cross the blood-brain barrier, or does so in very small amounts, and thus you have a decreased risk of the tardive dyskinesia that can result in the use of metoclopramide. And there were 3 large randomized controlled trials that were performed in the early 1980s that showed that it was equally effective, if not more so, to Reglan. A baseline EKG is recommended to be obtained before initiation of the drug because its major side effect is QT prolongation. And if you have a patient on therapy, you should periodically probably get EKGs as well. The makers of the drug have apparently never applied for FDA approval, and thus it's not readily available in the U.S., but there are programs that are available to procure the drug. And there are actually pharmacies both in the U.S. as well as in Canada and Great Britain that patients can legally obtain the drug through. When I was in Tyler, Texas, there was a pharmacy that employed a single person to formulate domperidone prescriptions around the clock. That's all they did. Apparently they sold so much of it they could employ a full-time employee to mix the drug. Another drug that is used that Dr. Muslow was asking if it was still employed is IV erythromycin. It's a motility agonist, and it's effective in the short-term treatment of hospitalized patients with gastroparesis. Unfortunately, as you continue to use it with longer duration of treatment, it leads to tachyphylaxis by downregulating the motilin receptors. There is some thought that because of the increased tone of the pylorus in gastroparetic patients, that by injecting botulism into the pylorus itself, that you could relax the pyloric tone and aid with emptying. And there's a randomized controlled trial that showed that yes, this was correct. This hypothesis was correct. By doing so, you could improve the degree of gastric emptying. Unfortunately, they did not see any symptomatic improvement in these patients, and thus, when the guidelines on the management of gastroparesis came out in the American Journal of Gastroenterology in 2013, they said it should not be used. Okay? This is not something that I've ever seen done. Dr. Jordan, have you ever? This is just a summary slide of the prokinetic agents and medications. Again, metoclopramide, start with 5 milligrams, monitor for tardive dyskinesia, use the minimum effective dose, and if you're using it for greater than 4 weeks, or certainly 3 months, you need to reevaluate its use. Domperidone starts at 10 milligrams with meals. You need to be very mindful of the possibility of QT prolongation and obtain a baseline EKG before starting them on therapy. It has typically a better side effect profile in comparison to the metoclopramide. Erythromycin, we typically start at 125 or 250 milligrams every 6 hours IV. Its long-term use is precluded by the development of tachyphylaxis, but it's very useful in the short-term improvement of symptoms in hospitalized patients. We often use antiemetics as well, but there's no evidence-based guidelines for their use in the management of gastroparesis. Unfortunately, abdominal pain and discomfort often accompanies gastroparetic symptoms, and reflexively, many physicians choose opiates to treat it, but we should really look for other alternatives, including tricyclic antidepressants, tramadol, SSRIs, or gabapentin. Unfortunately, a lot of patients, despite optimization of their glycemic control, aggressive medication therapy with metoclopramide or erythromycin, they have refractory symptoms, and these patients are very difficult to treat and maintain and keep out of the hospital. And so there are some salvage and alternative therapies that have been employed. There have been no large randomized controlled trials on any of these therapies, but this just gives a brief overview of some of the things that have been performed. So one of the things that can be done is to place a jejunostomy tube in the patient, but there's often a question as to how well the small intestinal motility is functioning, and it's often useful to determine first if they're going to tolerate jejunal feedings before you surgically place a J tube. And so a duodenal or nasojejunal tube can be passed into the small intestine, and then a slow feeding is initiated, where you have dilute infusions first that are gradually advanced to an isoosmolar preparation at a low infusion rate, typically 10 to 20 cc's an hour, and then up to a goal of about 60 cc's an hour for 12 to 15 hours per day. It's important to remember that the small intestine cannot tolerate bolus feedings like we do with PEG tubes. PEG tubes, you can give bolus meals 3 times a day in a very physiologic timing as normal oral feedings would do, but the small intestine can't tolerate that. So if you are able to determine that they're able to tolerate the small intestinal feedings, then J tubes can be used. PEG tubes are sometimes placed in an effort to vent the stomach and reduce their symptoms of nausea and vomiting. But this doesn't allow any improvement in enteral access to feed them because you would still be feeding the stomach. So sometimes we place PEG tubes or G tubes that have a jejunal extension where a tube goes into the stomach, through the pylorus, and down into as far as we can pass it into the small bowel. The problem is that oftentimes this J-tube extension will retract back up into the stomach, and we'll have to go back down with repeat endoscopies to push it down back into the small intestine where it needs to be. There are even people who have had both dual G and J tubes. It's not ideal. You have 2 different tubes protruding from the abdominal wall and the increased risk of leakage or infection with these routes. One additional modality for the treatment of refractory gastroparesis is through the use of a gastric electrical stimulator. These are implanted surgically into the abdomen and provide a high-frequency stimulation to the stomach. So you can actually see the electrodes of the stimulator here attached to implanted directly into the gastric wall. They can be considered in compassionate treatment in patients with refractory symptoms. Unfortunately, there's a real lack of randomized trial, and the availability of the device is limited. There are essentially 3 different types of gastroparesis. There's the diabetic gastroparesis, which we are discussing today, as well as idiopathic gastroparesis and post-viral gastroparesis. The latter 2 types have not been shown to achieve much improvement with these devices, and really they should only be used in patients with diabetic gastroparesis. The data do suggest that there may be some reduction in the weekly vomiting frequency. In terms of how you approach gastroparesis, this is taken directly from the clinical guidelines published in 2013. If you suspect gastroparesis, you should confirm a diagnosis and testing for the cause of the gastroparesis. You need to have some form of either an imaging study or an endoscopy to exclude a gastric outlet obstruction. You need to restore their fluid and electrolytes, counsel them on their dietary modifications, and of course improve and optimize their glucose control. And then initiate prokinetic therapy. Metoclopramide is considered a first-line agent in terms of prokinetic therapy. And if that fails, then consider a feeding jejunostomy, a decompressive gastrostomy, or a gastric electrical stimulator. Another slide that just looks at the various doses of drugs, which we talked about previously. So I'm not going to delve into this too much. But consider, especially when you're on the wards, consider the use of erythromycin. It tends to work at least short term. In fact, if we have patients that are coming in with a significant upper GI bleed, we often ask the emergency department physicians to go ahead and give them a dose of erythromycin while we are on our way to the hospital to aid with the emptying of blood from the stomach and allow better visualization during our endoscopy. All right, jumping ahead to small intestinal disorders. So celiac disease is actually much more prevalent in diabetics than in the general population. It's an immune-mediated enteropathy where gluten causes atrophy of the small intestinal villi and malabsorption. And it affects about 1% of the population as a whole, but its risk is prevalence is much higher in diabetic patients, especially type 1 diabetic patients, where they may have upwards of a 3 to 8% prevalence amongst type 1 diabetics. Mechanism for this is not understood. But if you have a type 1 diabetic in clinic that is complaining about the new onset of diarrhea, has weight loss, or has the development of intermittent hypoglycemic episodes, you should consider this as a possibility for the cause of their symptoms. In the vast majority of cases, Type 1 diabetes is diagnosed before that of celiac disease. The symptoms in terms of classical celiac disease are fairly typical, where you have diarrhea, steatorrhea, abdominal pain, and weight loss. However, we do see patients that have silent celiac disease, where they're diagnosed on serologies alone or during endoscopies and histologic analysis. There's a nice article in the New England Journal of Medicine that came out in 2007, and really beautiful figure on the left here that shows how gluten interacts with environmental, immune, and genetic factors in celiac disease. And so you have a patient that ingests gluten, and gluten is a storage protein that's derived from wheat, rye, or barley. And when gluten is digested by brush border enzymes or luminal enzymes into amino acids and peptides, one of the polypeptides that it's digested into is gliadin. Normally, gliadin is undigested, but patients with celiac disease have defects in their intestinal epithelium, and so the gliadin is allowed to cross through the epithelium and into the lamina propria. This initiates both an innate and adaptive immune response. In the epithelium, the gliadin actually damages the epithelial cells and results in the overexpression of interleukin 15, and which results in the migration of intraepithelial lymphocytes into the epithelium itself. And when gliadin enters the lamina propria, down here, it's digested by tissue transglutaminase, which allows for the interaction of the HLA-DQ2 or DQ8 haplotypes that are present on antigen-presenting cells. What happens next is that antigen then gets presented to CD4 T cells, which activate a cytokine release, further damaging the intestinal villi of the small intestine, as well as activating B cells to produce antibodies to gliadin. This results in the development of villus blunting and a large degree of inflammatory component within the small intestine compared to a normal patient on the right, where the villi are nice and long and healthy and much more blunted and shortened in the picture on the right. In terms of diagnosing celiac disease, the testing of the patients for tissue transglutaminase, IgA, is the preferred serologic test. It has a very high sensitivity and specificity. Patients with IgA deficiency, however, will not have a detectable serum tissue transglutaminase antibody, and therefore, if you have a high suspicion for the disease and you have a negative tissue transglutaminase test, you really need to make sure that they don't have IgA deficiency and check their IgA levels. The anti-endomysial antibody has a similar profile, but it's not typically used first line because it's much more expensive. And anti-gliadin antibodies are of limited value because of their low sensitivity and specificity. However, duodenal biopsies remain the gold standard for diagnosis, and if serologies are positive, upper endoscopy with duodenal bulb and distal duodenal biopsy should be obtained. The endoscopic appearance may be abnormal, as represented by this picture here, where you're looking at a portion of the second duodenum, and you can see some subtle scalloping along the edges of the folds. What's the treatment? There is only one treatment, and I've had patients argue with me about this, because the only thing that can be done is that you have to eliminate dietary wheat, rye, or barley from their diet. This is the only thing that's been shown to improve symptoms, improve mortality, and possibly reduce the risk of cancer, because these patients are at an increased risk for the development of small bowel adenocarcinomas and lymphomas. You also need to assess for nutritional deficiencies in these patients. They tend to be deficient in folic acid, vitamin B12, or iron, especially if their proximal small intestine or distal ileum is affected. They tend to have low calcium levels and be deficient in fat-soluble vitamins and have an increased risk for osteoporosis. Another small intestinal disorder is small intestinal bacterial overgrowth, and this is where a patient develops alterations in the type and quantity of bacteria within the small intestine that can lead to symptoms of bloating, abdominal pain, diarrhea, and gas. Unfortunately, these symptoms can be vague and often overlap with those of IBS, but in a patient with diabetes and diarrhea, especially if they're having a lot of flatulence or bloating, this should be considered. Patients that have had prior abdominal surgeries, especially those where they have blind loops of small bowel, this can result in the creation of reservoirs that enable the growth of bacteria, and the bacterial byproducts produced by these organisms can interfere with the normal absorption of fat and carbohydrates. And you can actually have a development of deficiencies in fat-soluble vitamins, and the anaerobic bacteria that are over-colonizing the small intestine can actually metabolize vitamin B12 before it can be absorbed by the patient. If you do testing in these patients, they may have low vitamin B12 levels but high folate levels. So the diagnosis, the gold standard, has long been considered to be general aspiration during upper endoscopy. I don't know anybody that does this. SIBO is defined as having a greater than 100,000 colony-forming units per milliliter in comparison to what is considered normal, where you have less than 10,000 colony-forming units per milliliter. But the costs and risk of doing an upper endoscopy and deeply intubating the small bowel really limits its use, and therefore we tend to go straight to treatment where we try to optimize any motility disorders, assess and correct for nutritional deficiencies, and most importantly, treat them with antibiotics. Rifaximin is one of the ones we typically use. Unfortunately, it is expensive. It's nice in that it's not typically thought to be systemically absorbed. But doxycycline, augmentin, and flagyl are used with great success in clinical practice as well. Unfortunately, recurrence is common in these patients, especially if they have a structural abnormality like a blind loop. So they can get better once you treat them with antibiotics, have a period where they are asymptomatic, and then the symptoms can recur, and you need to give them repeated courses of antibiotics throughout their lifetime. Diabetic diarrhea is another potential adverse GI symptom and disorder that can develop. Diarrhea in diabetics can be due to a number of different causes. Number one, you can have ingestion of artificial sweeteners. You need to be mindful of the possibility of concomitant celiac diseases, small intestinal bacterial overgrowth, IBS, and of course medications, metformin being a common culprit in these patients. Especially with patients that have had poorly controlled and long-standing diabetes, they can also develop autonomic neuropathy of the intestines. The diagnosis here is one of exclusion. Symptoms typically are watery, voluminous diarrhea. They often have nocturnal symptoms. Fecal incontinence often goes along with this type of diarrhea, and they typically have no abdominal pain. Again, treatment begins with optimization of glycemic control. We tend to use antidiarrheal medications in an effort to slow down their stooling. Additional therapies outside of the traditional antidiarrheal medications include clonidine, as it can provide some adrenergic stimuli to aid with fluid and electrolyte absorption. Octreotide has also been employed. You need to be cautious with its use because it can actually increase the risk of small intestinal bacterial overgrowth due to the possibilities of both hyperglycemia, but you can also see hypoglycemia in these patients as well, because octreotide is an inhibitor of glucagon and insulin. Looking briefly, because we're running out of time here, large intestinal disorders, fecal incontinence is sometimes a problem. It's very difficult to treat. Usually a consequence of autonomic neuropathy, especially if they've had any prior anal sphincter injuries from childbirth or previous surgeries. Its incidence approaches about 1% in the general population and increases with age. Symptoms often start out with low volume diarrhea, accompanying the fecal incontinence. Nocturnal symptoms tend to be particularly problematic. And again, it's typically present in patients that have had long-standing disease. You need to exclude fecal impaction in these patients that can have overflow incontinence, exclude infectious etiologies or mucosal abnormalities within the rectum and colon as well. And anorectal manometry is the primary method that we use to define the deficits in fecal incontinence. Constipation is actually more prevalent than diarrhea in patients with diabetes. So 60% of patients with long-standing diabetes can have some slowing of the motility of the large intestine. And you can have very severe cases where patients present with megacolon or even colonic pseudo-obstruction. You can even get stercoral ulcerations, which are areas of pressure, necrosis, and ischemia within the rectum or distal sigmoid colon. There's a big ulcer here, as well as here in a patient that was diagnosed with stercoral ulcers due to presenting with GI bleeding, who had a previous history of severe constipation. Lastly, I'll briefly touch upon hepatobiliary disorders and pancreatic disease. This is, I'm not sure where my picture is, something we could spend an entire additional lecture on, but you should be aware of the development of non-alcoholic fatty liver disease as having a high degree of prevalence in type 2 diabetic patients. You have non-alcoholic fatty liver disease really encompasses the full spectrum of two different entities, where you have non-alcoholic fatty liver disease as well as non-alcoholic steatohepatitis. NASH is different from NAFLD in that you actually have fat deposition within the liver with inflammation. That is the most important key distinguishing factor here. This is a pathology from a liver biopsy in a patient with non-alcoholic fatty liver disease. All these white areas are where there were globs of fat deposited within the liver. Okay? There's a little bit of fibrosis represented by green here, but you don't see a large degree of fibrosis, and you certainly don't see a lot of lymphocytes that are suggestive of inflammation within the liver. Fortunately, my other picture is not showing up. Gallbladder dysfunction is common in type 2 diabetics. They are more prone to the development of cholelithiasis as well as choledocholithiasis. They typically have a more lithogenic bile composition compared to normal controls, and there is stasis of bile in the gallbladder that contributes to a higher rate of stone formation in these patients. Pancreatic insufficiency can often develop as well. About 30 to 50% of patients with type 1 or type 2 diabetes will have some element of measurable biochemical insufficiency. Fortunately, the minority of these patients will have any adverse symptoms. When diagnosed in patients that have clinically significant cases, you treat with pancreatic enzyme supplementation. And finally, acute pancreatitis is much more common in diabetics than in the general population. If you have type 1 diabetes, your risk compared to normal controls is about doubled. But if you have type 2, your risk is nearly tripled. And if you are on a GLP-1 agonist or a dipeptidyl peptidase 4 inhibitor, you have an almost 6-fold increase in the rate of pancreatitis. Obesity and hypertriglyceridemia are thought to be common risk factors, as well as some element of chronic indolent underlying inflammation present in the pancreas in these patients. Finally, concluding here, GI complications of diabetes can affect any organ in the GI tract, and they can result in significant morbidity and adversely impair quality of life. While screening for heart disease, retinopathy, and neuropathy, as well as nephropathy, are typically performed during clinic visits and documented in the electronic medical record, GI symptoms related to diabetes are often ignored and therefore not treated. And it's important to be cognizant and know how to treat them and when to refer to a gastroenterologist for more formal evaluation when necessary. Thank you. Questions?
One comment. I think we too often see patients who have some GI symptoms and quickly get labeled as gastroparesis without further diagnostic study and put on dangerous medicines.
The problem when patients come in with what appears to be a flare of gastroparesis is that they oftentimes are too ill to undergo the formal gastric emptying study. You know, you have to keep down the food that you ingest for the gastric emptying study to go through with the full test. And if you can't do that, then you can't diagnose them. It's really not the appropriate time when someone comes in with an acute flare to try to test them. You need to get their glucose controlled as best as you can and then bring them back for a gastric emptying study. Yeah.
Do we have any way to get a hold of domperidone here? Because I've tried before without being able to get.
Yeah, I have a couple of patients on it. If you email me, I can give you where I tell my patients to get it from, or actually I even prescribe it to them through a pharmacy out of Miami. Any other questions? All right.